It's really an honor to be here. So at Medic Mobile, our mission is to dramatically improve the health and well-being of the world's most underserved and most disconnected. And really what I want to deliver today is a message as to why I'm so optimistic and to bring all of you on board with us. And I'll start my story with technology. Began when I was a student at Stanford in Palo Alto, and I was dead set. I was sure I was going to be a doctor. I was on the path to medical school, slaving away in the chemistry lab, and that was my path. And I figured I should walk the walk. I should understand the realities of global health. And I ended up at a rural hospital in Malawi. This was in 2007. And at this hospital, there was one doctor, and he was serving about 250,000 people. And those patients were walking or ox carting up to 100 miles to get to that hospital and to get to that doctor. They were spending 10 days, in some cases, 10 days trying to get to that doctor. And I realized pretty quickly that this was status quo in global health, that there are 1 billion people alive today who will go from birth to death without ever seeing a health professional, without ever seeing a doctor even once. So they didn't have access to clinics, certainly not to formal health systems. And if they did happen to reach a hospital, this was the system. So this I took in DRC in Kinshasa about 6 months ago. And this is at the biggest government hospital in the one urban setting in the country. And this is the best system there. And if you can't tell, this is basically an information and data black hole. Once something goes in here, it doesn't come out. This is the patient record system. But what people did have access to were really two things. The first were community health workers. And this is Dixon in the middle of this photo. And when I met Dixon in 2007, he was walking 40 miles a week to hand deliver paper reports for about 40 HIV-positive patients he was basically looking after in his home village. And I've sort of figured out that we've implemented this strategy since about 1970 all over the world. There are 10 million community health volunteers scattered throughout the most rural and underserved areas of the planet. There are 1.8 million across India, 1 billion in China, 100,000 in Bangladesh, 50,000 in Nepal. Pretty much anywhere you go, you can meet. You can go into a village and say, who's your community health worker? And they'll lead you to their door. The second thing is mobile phones. That's why I'm here today. So I was out with Dixon, that community health worker, and I had a better mobile coverage at his home village than I did in Palo Alto. This was 2007. There's this really amazing dramatic shift. Today, 50% of people in Sub-Saharan Africa own a personal mobile phone. Experts say that'll be close to 100% in about 2 years. And I've just learned to shorten those expectations. So in a year and a half, we'll see about full penetration of mobile phones, even in Sub-Saharan Africa. And so in this case, we basically put 2 and 2 together. And I put 100 cell phones into a backpack. Not sustainable or scalable, but it got things going. 100 phones in a backpack, smiled at customs officers on the way back to the hospital, had a copy of some free software, put in a GSM modem, and this let us just basically try things with something as simple as text messaging. And they were doing active case finding for tuberculosis. They were finding patients who weren't coming in for HIV appointments, and they doubled the number of patients they were treating for TB in 6 months just by exchanging text messages. We now work in 16 countries, everything from stock monitoring and maternal health surveillance in rural Ethiopia to diabetes management in the free clinics in and around the Bay Area. And it's really been amazing. I was in Nepal in November, and it was really demonstrative. I was basically at a hospital on the mountainside, and the furthest communities that are expected to come to that hospital are a 7-day trek. And if you go 6 hours in between each village cluster, you run into basically populations of about 300 people at each stop. And at each stop, I had 6 bars of mobile signal. It's really unbelievable. And the next 1 billion new mobile connections, people who aren't connected today but will be connected tomorrow, it's exactly where we care about most. It's the rural developing areas of the world, and they're going to be low-end, really scalable devices that are really shipping faster than any technology we've ever seen. And we looked hard at our users, and mostly community health workers and patients and caregivers, and looked at what was already in their hands. And it turns out it's a diverse range of really low-end devices, heavily subsidized by the mobile operators, sometimes even governments. But these come out to between $8 and $10 a phone. And we thought about what they could do. We knew they could do text messaging, and we had basically pushed it to its limits. It could do voice applications, but it turns out you can also run apps directly off of the phone's SIM card. And the SIM toolkit is a GSM standard. It works across any mobile phone. The trick was getting apps onto the native SIM cards that the mobile operators were shipping. And that takes long, convoluted discussions with consumer departments. And if people in mobile operators want to talk about that, I'd love to. But we needed a shortcut, basically. And we found some technologists in Prague who had basically figured out how to put a small microcontroller onto a paper-thin wafer that was thin enough to slide in next to an existing SIM card. So parallel SIMs, no one's really used them for anything except for jailbreaking iPhones, but we're using it to run health applications. And the neat thing is we have a bunch of different models. And in this case, you can see the wafer slides right next to the SIM card. The microcontroller wraps around the mobile phone's battery and slides in just between the battery and the mobile phone's case. And the cool thing about SIM apps is that it presents in the native menu. So this is a stock monitoring app running on an iPhone and a low-end throwaway Nokia. And whatever you are familiar with your phone, whatever native user interface you're used to, that's how the apps present. This can do data validation. It can do skip logic, which lends itself to treatment protocols and things like that. We can ship it with near-field communications to gather data from peripheral devices, which we're really excited about. But sometimes we don't need to do really complex things. Sometimes we just need to make use of basically slivers, small stories, sometimes just in 160 characters or less. And probably the best description of this is the response to the earthquake in Haiti in 2010. So in this case, about 1% of the population was online, had internet access. About 1% of the population had a landline phone. But fully 80% of people in Haiti either owned or had immediate access to a mobile phone. And after the earthquake in 2010, the US government and the mobile operators prioritized the GSM network, and the only thing still getting through that network were text messages. So we turned to that. I put out a tweet that I was looking for someone to help me set up an SMS gateway. And this is my Twitter story, for the record. So 4 minutes later, somebody following me from Cameroon put me in touch with an engineer in Haiti for Digicel. 10 minutes after that, I was Skyping with the State Department and his boss. And within hours, we had a short code, 4636, that was free for anyone to text into. And along with colleagues, and I'll ask Brian Herbert to raise his hand in the front row, we basically set up a system where anyone could text in their need and their location for free. We went radio station to radio station in Port-au-Prince. And this is what the messages looked like. They were mostly in Haitian Creole, with sort of vague references to location. And the challenge here was how we make sense of this and make it actionable. We were gathering all these needs. How do we make it actionable? So we turned back to the internet and recruited about 3,000 people from all over the world. These are their IP addresses mapped. And what they were doing was mapping, categorizing, and translating every single message. And they ended up processing about 100,000 text messages in the first 2 weeks after the earthquake, usually within 3 minutes of each message received. And these were population-level information. So we had an IDP camp of a couple hundred people that sprung up outside Port-au-Prince. We got about 300 text messages from them over the course of 2 days saying they urgently needed food and water. The Red Cross went out and verified those reports, and the next day, they were included in aid logistic routes. To also very personal stories. So we had a woman who was bleeding out, who had postpartum hemorrhage during labor, and a bystander texted in, and within 10 minutes, the US Coast Guard was responding and assisting with birth because it was actionable message. The volunteer from Montreal who grew up in Port-au-Prince had the GPS location pegged to 10 decimal points, both latitude and longitude. And this is an example where these 100,000 very small stories gave us an unprecedented picture of what was happening over time. So what you see here are all the text messages and their categories mapped. And on the left, you can see day 1, a big spike in missing persons and deaths. You can see collapsed structures and emergencies in black at the bottom. And then within a day, a shift to US search and rescue, to health services and emergency medical care, before a big bulge in both food and water needs after about 5 days. And in this case, we were really focused on understanding the needs and then seeing how we could respond. In other cases, we're trying to keep people in life-saving programs. And this is actually brand new data, and I haven't shared this with anyone else, so I'm really excited to share it today. We're running a randomized controlled trial in India where about 50% of children are not vaccinated. So 50% get full vaccinations, 50% are missing some. And what we wanted to do is figure out how we directly engage caregivers, so often mothers and grandmothers of these kids, and how we might be able to get these vaccination rates up. So we're at 50% at baseline, and we're now about a year into the study, and for doses 1, 2, and 3, the coverage rates are 95, 99, and 100%. And the intervention is incredibly simple. They're basically text message nudges to the caregivers to basically remind them to bring their children in. And if they miss a certain appointment window, a subsequent nudge is sent to the community health worker that's meant to watch over that village. And so it's activating the next layer of the social network and getting a face-to-face interaction to keep them in that system. So we're really trying to experiment and understand the true power of nudges and text messages that cut through very busy lives. The second thing we're trying to do is take talent and ideas from the private sector, talent and ideas from the Silicon Valley, and apply them to global health challenges. So we asked a computational linguist at Stanford, Rob Monroe, to basically look at a really large data set of communications between community health workers, patients, and doctors in rural Malawi, where there were 20 different spelling variations for any given symptom, or mostly in Chichewa, which is a Swahili derivative, so really challenging language data sets. And he ended up building some AI that was 99% as accurate as a human being in tagging and auto-categorizing these messages. And this has huge implications for disease surveillance, and I like to think of it as sort of useful machine learning. The second thing I'm really excited about are point-of-care tools. So I already talked about how we might gather data from a Band-Aid monitoring device that's currently being designed for fall monitoring and monitoring the elderly population in the US that we're going to repurpose to monitor high-risk mothers on the mountain in Nepal. But also, as data networks expand, and I would love to see that infrastructure move even faster, once we have mobile data, imaging tools, they're just going to be really exciting. So we're working with a colleague. His device is pictured on the right, Adigan Ozcan, based out of UCLA. And what they've done is basically figured out a $15 camera phone add-on that lets you do intracellular imaging. So you slide a blood sample into the back of the phone, you shine an LED on that blood sample, which creates a shadow image that's then transferred by picture message. The software basically compares that to a cell library and then shoots back a text message with the diagnosis. And this is for HIV, tuberculosis, malaria, complete blood cell counts. This is going to change how we know who needs what and where in global health. And I can't wait. And from what we're seeing, it seems that we're moving towards an era of collective consciousness. Basically, what one person knows, everyone knows, or what one person knows, everyone who cares knows. So when that mother shows up at a clinic and they're out of malaria drugs and they have to walk another 20 miles to the nearest clinic, as soon as that happens, anyone who might seek care for malaria knows that information already. So it's about networked intelligence, and Mr. Tapscott and Tim O'Reilly are probably going to talk about that a little bit tomorrow, but I think it has direct implications for global health. And the other question we ask ourselves almost every day is, what's the point? Why are we doing this? What holds our team together? And this is also the title of the talk, but what we're trying to do here is reach for equity. And we're trying to make a value statement about what future we want to create as opposed to just being along for the ride. And this is an overhead Google image shot from Google Earth of a village cluster in Malawi, and basically a village cluster in suburbs of Virginia where I grew up. But the same amount of people in both cases, dramatically different life expectancies, dramatically different access to clean water, to health services. And basically the point is that we need to take equity seriously. That we really believe at our core that it shouldn't matter where you're born, that health is a human right, and it's our responsibility to design systems for that right. And that's really why we're here and why we're using technology. And I really would love your help. So if there are problem solvers out there that want to connect, please come and find me. I also make it really easy to find us online. And we feel it's our responsibility to give a way to act to basically anyone. And we started with a statistic in the United States that every single day, 500,000 cell phones are put into desk drawers and trash cans. The rate at which we are discarding mobile phones is unbelievable. And so the pitch with Hope Phones, which is a campaign we're running in North America and hoping to expand, is that you can give your old phone a new life on the front line of global health. So we cover all the logistics, we recycle your phones, and the proceeds directly fund hardware that we purchase in local markets for our projects in 16 countries around the world. So we'd love to talk to anyone here who feels the same way that we do, and I'm so grateful for you having me here. Thanks.